Then ask the patient to squeeze your fingers as hard as possible. Normally, you'll have difficulty removing your fingers from the patient's grip. Other areas to test for muscle strength include the following: flexion at the elbow, which involves spinal nerves C5 and C6, and extension at the elbow, which involves spinal nerves C6, C7, and C8. Also test opposition of the thumb, which involves spinal nerves C8 and T1 and the median nerve. Flexion at the hip, which involves spinal nerves L2, L3, and L4. Extension at the knee, which involves spinal nerves L2, L3, and L4. And flexion at the knee, which involves spinal nerves L4, L5, S1, and S2. Finally, test dorsiflexion at the ankle, which involves primarily spinal nerves L4 and L5, and plantar flexion at the ankle, which involves primarily spinal nerve S1. Grade muscle strength on a scale from 0 to 5 as follows. 0, no muscular contraction detected. 1, a barely detectable flicker or trace of contraction. 2, active movement of the body part with gravity eliminated. 3, active movement against gravity. 4, active movement against gravity with some resistance. And 5, active movement against full resistance without evidence of fatigue. This indicates normal muscle strength. When you're performing a nervous system exam, you'll also test the patient's deep tendon and superficial reflexes. To elicit a deep tendon or muscle stretch reflex, use a reflex hammer. The pointed end is useful for striking small areas, while the flat end is useful for striking larger areas. Have the patient relax, then properly position the limb to be tested. Holding the reflex hammer between your thumb and index finger, quickly strike the tendon, using wrist motion only. Be sure to compare one side to the other. Grade the reflexes on a scale of 0 to 4 plus as follows. 0, no response. 1 plus, somewhat diminished, below normal. 2 plus, average or normal. 3 plus, brisker than average. 4 plus, very brisk, hyperactive, and often associated with clonus. Use a stick figure to record your findings. A hyperactive response suggests upper motor neuron disease. Diminished or no response suggests damage to the lower motor neurons or relevant spinal segments, a loss of sensation, or disease of the muscles or neuromuscular junctions. Here are the deep tendon reflexes commonly tested during a nervous system exam. Test the biceps reflex, which involves spinal nerves C5 and C6. Observe for elbow flexion and watch for and feel for biceps muscle contraction. Test the triceps reflex, which involves spinal nerves C6 and C7. Observe for extension at the elbow and triceps muscle contraction. Test the brachioradialis or supinator reflex, which involves spinal nerves C5 and C6. Observe for flexion and forearm supination. Test the patellar reflex, which involves spinal nerves L2, L3, and L4. Note the extension of the knee and quadriceps muscle contraction. Test the ankle reflex, which primarily involves spinal nerve S1. Watch for and feel for plantar flexion at the ankle. Also note the speed of relaxation after muscular contraction. Next, test the abdominal reflexes and the plantar response. These are superficial or cutaneous reflexes. initiated by stimulating the skin rather than muscle. When assessing the abdominal reflexes, keep in mind that the area above the umbilicus involves spinal nerves T8, T9, and T10, while the area below the umbilicus involves spinal nerves T10, T11, and T12. Watch for the contraction of the abdominal muscles and deviation of the umbilicus toward the stimulus. When assessing the plantar response, which involves spinal nerves L5 and S1, watch for flexion of the toes. Normally, they'll flex. But if you see dorsiflexion of the big toe and fanning of the other toes, the patient has a Babinski response. This suggests an upper motor neuron disease or that the patient has lost consciousness. The posterior root of the peripheral nerves carries the sensory or afferent nerve fibers to the spinal cord and brain along two pathways. The spinothalamic tracts, which conduct the sensations of pain, temperature, and crude touch, and the posterior column of the spinal cord, which conducts the sensations of position, vibration, and fine touch.
This Perry, we're going to move right ahead and start.
When assessing pain, temperature, and touch, keep these points in mind. Compare distal areas to proximal ones. Compare symmetrical areas on each side of the body. And scatter the stimuli to assess most of the dermatomes. To assess pain sensation, ask the patient to close her eyes. Then touch her skin with an open safety pin or other sharp object. Ask her to tell you whether it feels sharp or dull. Occasionally, substitute the blunt end of the pin for the point. Compare areas as you go along. To prevent transmitting infection, discard the pin safely. Never reuse it on another patient. Assess temperature sensation if the patient's pain sensation is abnormal. To do so, have her close her eyes, then touch a test tube filled with hot water to her skin. Ask her to identify whether the test tube is hot or cold. Repeat using a test tube filled with cold water. To assess touch, have the patient close her eyes, then lightly touch her skin with a fine wisp of cotton. Ask her to respond whenever she feels the cotton. When assessing vibration and position sense, test the fingers and toes first. If these are normal, you can assume that the more proximal areas will also be normal. If the patient has loss of vibration or position sense, suspect a peripheral neuropathy or a posterior column disease. To assess vibration, tap a low-pitch tuning fork on your hand. Place it over a distal interphalangeal joint of the patient's finger and ask what she feels. Now, place it over the interphalangeal joint of the big toe and again ask her what she feels. To assess position sense, grasp the patient's big toe and pull it away from the other toes. Show the patient how you'll be moving her toe up and down. Then ask her to close her eyes and to tell you whether her toe is up or down as you reposition it. Repeat this action several times on each side. Next, assess discriminative sensations, but only if touch and position sense are intact. An abnormality suggests a posterior column lesion or disease. Test discriminative sensations by assessing stereognosis, the ability to identify an object by feeling it. To do so, have the patient close her eyes, then place a familiar object, such as a paperclip, in her hand. Ask her to tell you what it is.
Feels like a paper clip.
Normally, the patient will manipulate the object skillfully and identify it correctly.
Would you close your eyes?
If the patient can't manipulate an object, test her ability to identify numbers, which is called graphesthesia. Write a number on her palm Ask the patient to identify it.
That's number 5.
Normally, she can. Other discriminative sensation tests that may be performed include 2-point discrimination, point localization, and extinction. Now, let's review the primary areas you'll assess when examining the nervous system. They are mental status and speech, the cranial nerves, the motor system, the reflexes, and the sensory system.
All right, we're finished with your examination.
When you've finished the examination, have the patient dress, then discuss your findings with her. Be sure to correlate the patient's health history with your findings.
Yes, I do have a few.
This program has presented both the key skills you'll need for a thorough and accurate nervous system assessment, plus the background knowledge required to evaluate your findings. Review it again and again. Then master each step you've learned with practice to ensure your reputation for quality